Great, thank you. Welcome everybody to the first CIC lecture of this season. Today we have Dr. Maggie Davis, who is a a clinical psychologist and associate professor in the Yale Department of Psychiatry, co-appointed in the Department of Psychology. Her bio is really long, but you can read it on the website. I'll just jump to the point. Today's talk will be on Kappa opioid receptor as a novel potential target for suicidal risk and prevention in trauma survivors, evidence from the 11 CEKAP PET imaging studies. Now the floor is yours, Maggie.
All right, thank you so much. I will try to project. I have a naturally somewhat soft voice, so if I need to speak louder at any point, please feel free to interrupt me and let me know. It is my pleasure to join you today and have a chance to talk about my lab's work examining the role of the opioid receptor system and specifically Kappa opioid receptor system in trauma-related psychopathology and risk for suicide. And I want to start out today by setting a scene very generally first to give some context for what motivated this study that I'm going to be discussing and how it fits into what we understand so far about suicide and trauma. So it goes without saying that suicide is one of the leading ongoing sources of public health concern in both the US and worldwide. We lose about 850,000 people every year to suicide. That's actually more than both war and homicide combined internationally. And while rates of suicide fatality have decreased by almost 1/3 in recent years internationally, which is fabulous news, that includes Canada, with the exception, as I understand it, of the past 2 years where rates have just about flattened out, rates of both fatality and attempt have continued to increase in the United States by a pretty significant percentage for every year for which we have full data since the year 2000. So this has been going on for quite some time. And of particular concern, rates of suicide behavior have been increasing in teens and young adults in particular, to the point that suicide is now the third-rate leading cause of death worldwide in individuals aged 15 to 29 years old. So understandably, identifying mechanisms both neurobiologically and behaviorally that underlie suicide behavior so that we can significantly facilitate risk reduction and prevention efforts is and should be a high priority. And we still have a long way to go, but we've also had some pretty significant developments and discoveries. Researchers have succeeded, for example, in identifying a few variables that are pretty reliably associated with the escalation of suicide behavior from thought to attempt, and even in predicting death by suicide. And notably, for today's talk in particular, these include both PTSD and borderline personality disorder, so two psychiatric conditions that are associated with the experience of trauma. And keep this in mind because I'm going to be talking a good bit more about this a little bit later on. But I want to take a step back for a moment and talk in a little bit more detail about suicide, because I think we tend to talk about suicide as if it's a singular phenomenon. And I think it's important to keep in mind that when we talk about suicide, what we're actually dealing with here isn't a single behavior. This is a complex set of behavioral phenomenon which can be broken down from a clinical and risk management perspective into a few different stages. So recent research as well as clinical work tends to break down suicide behavior based on escalation behaviorally, from thought to action, so from ideation to planning to attempt and through to death by suicide. And as you can see from this diagram, it's even more nuanced than that. There's more nuanced terminology to discriminate between these forms of behavior, and that matters in this context because there's evidence, and increasing evidence, in fact, so to suggest that these phenomena differ neurobiologically as well. So presentation of each of these behaviors is both clinically and neurobiologically complex, and looking at them together can obscure potentially meaningful differences. And to illustrate the complexity a little bit further of these behaviors, I want to just briefly discuss some data from an EMA, or Ecological Momentary Assessment study, that was conducted looking at suicide ideation. The specific study recruited from an inpatient sample of 50 adults. And what they asked the adults to do, all of these adults were inpatient following a suicide attempt. They were receiving treatment, and they each assessed suicide ideation, so the extent to which they were having thoughts of suicide multiple times during the day, during the time that they were inpatient. And then the researchers used the data to perform a latent profile analysis so they could look at distinct phenotypes of suicide thinking. So different patterns in frequency, intensity, and variability in suicide ideation. And as you can see, what they found, interestingly, was that there are meaningful distinctions. So there were 5 different phenotypes of suicide thinking that emerged that differed primarily on intensity and variability of suicide thoughts. What they then did was use these profiles to predict post-inpatient hospitalization who would go on to engage in suicide behavior, specifically to attempt suicide and unfortunately to die by suicide. And what they found was that the individuals who had a high mean with low variability were the individuals who were at the highest risk for subsequent attempt and for subsequent death by suicide. So this is important because clinically, these findings suggest that we want to not only assess clients' average level or certainly single time point level of suicide thinking, we want to understand variability around the mean. But the other thing that I want to point out here is that that's not the only high risk group, right? High mean with low variability is high risk. But we also lost a fair number of people in this study. So by death, we had a fair number of people who attempted suicide, and a fair number of people were lost to death by suicide in this group who had high mean, but also very high variability. So at some time points, they were reporting no suicide or very low suicide ideation. At other time points, they were reporting very high suicide ideation. And those time points were linked to stress. This would be more commonly what we would expect to see in trauma-related psychopathology. These would also be patients for whom it would be more difficult for us to predict clinically when they might be at risk for suicide behavior. And I think that that's meaningful and important to consider. I think it's also worth noting up front that the degree of complexity makes it incredibly difficult for us to reliably predict who's going to die by suicide, unfortunately. In fact, a recent meta-analysis on suicide risk reported that 95% of high-risk patients, so people who are displaying multiple suicide-related characteristics defined by a high propensity for suicide mortality, did not attempt suicide at follow-up, whereas 50% of individuals who were rated as low risk for suicide did go on to attempt suicide. So I think that just really underscores the complexity of trying to predict, trying to prevent, trying to be effective in terms of both prediction and prevention for this set of behaviors. On the positive side of things, we've seen a significant growth in suicide neuroimaging research. So our understanding of suicide behavior and our ability to develop successful and effective treatments has notably advanced and exponentially advanced in the last 20 years, particularly most recently with focus on adolescents. And this only goes to 2018. I don't have the exact numbers, but I'll say this exponential growth has continued up until present day. And cumulatively, here is the result of that growth. I'll say up front that this model, while useful, to me initially is a little bit overwhelming. And as highlighted here, suicide behavior can be seen as a complicated process in which genetic, neurobiological, environmental, psychological factors all interact in a complex pattern. And what we've done is identify a number of diffuse potential targets of relevance. So the question becomes, how do these interact? Where do we start? What do we do? How do we apply this clinically? Where do we go next? My doctoral training is in clinical psychology. I'm a neuroimaging researcher primarily now, and I'll acknowledge that that initial training does shape how I answer that question. I'm a researcher, I'm also a clinician, I'm also an advocate. And from a therapeutic perspective, arguably one of the most essential goals is development of a pharmacotherapeutic agent that's capable of acutely reducing suicide risk. Therapy takes time, skills take time to build and translate, and most drugs take time to build up in the system and become effective. But suicide death rate is 300 times higher in that first week after release from inpatient hospitalization and 200 times higher in the first month. So we need treatments that are capable of affecting suicide risk and doing that rapidly. And that's why the focus of my work has specifically been on the glutamate and the opioid system, both of which research suggests may contain targets where we can have rapid acting therapeutics with anti-suicide properties. The first of which, as I'm sure many of you, if not all, have heard of, is ketamine. This is just one of many published clinical trials demonstrated the suicide or potential anti-suicide reducing properties of ketamine. This specific study recruited 30 patients from an emergency department. It was conducted some time ago between August 2016 and 2018. They randomized intranasal ketamine to 40 milligrams of saline placebo in this case for these patients. And they showed relatively robust remission from suicide ideation in about 80% of patients who were in the ketamine group, relative to 33% of patients on the control group. So the mean difference in depressive symptoms was also pretty significant, about 9.75 points on the depressive symptom scale. That said, we're talking about trauma today, and there are some populations for whom ketamine may not always be the optimal choice. So I mentioned earlier that some of the most reliable predictors of suicide risk are trauma-related conditions, including borderline personality disorder and post-traumatic stress disorder. In fact, both BPD and PTSD specifically are associated with markedly increased risk for all forms of suicide behavior. And just to underscore the importance of the relationship between these disorders and suicide behavior, PTSD specifically, in a recent meta-analysis that examined relative risk, was shown to be associated with roughly 100 to 300% increase in suicide risk. And in veterans, that's increased even further, over 300% risk for not just suicide, death by suicide, but also suicide attempt. So keep that in mind. Keep that in mind as we talk about what we're going to be talking about today. And unfortunately, estimates for suicide behavior in BPD are at least as high, if not higher. Up to 3/4 of individuals with borderline personality disorder will attempt suicide in their lifetimes. The majority of them when they're young, so before the age of 35. And individuals who attempt suicide with borderline personality disorder usually don't do that once. It's usually an average of between 2 and 3 times. And an estimated 10% of individuals with borderline personality disorder die by suicide. Another way of saying that is 50 times the rate of the general population, or up to a third of the deaths by suicide in the United States can be accounted for by individuals in this subpopulation. So an enormous portion of the individuals that we lose to suicide are individuals with trauma-related psychopathology. Exploration of novel treatment targets that are capable of affecting suicide behavior and risk in these populations is essential, but unfortunately, the evidence so far is extremely mixed with respect to the potential for any agent, and ketamine specifically, to affect PTSD or BPD. A recent review highlighted some promising results in preliminary studies in PTSD, but with a lot of heterogeneity. And in BPD, the first study was actually done by my colleague Sarah Feinberg here at Yale, but was generally, unfortunately, not supportive of specifically the anti-suicide properties of ketamine for BPD. There's been some promising studies and specifically case studies since. Really mixed results so far. We also worry about ketamine because ketamine is a dissociative anesthetic. And the reality is dissociative subtypes of PTSD and dissociation in BPD is a risk factor for death by suicide and for suicide behavior. So putting somebody in a dissociative state deliberately is something that we worry about clinically. Not necessarily something that we are going to eliminate a potentially promising treatment for, but certainly something we're going to think about clinically in terms of the potential risk. So what are our alternatives? What are other potentials? Well, there's been some recently extremely promising evidence that suggests that the opioid system might have some potential promise for rapid acting suicide prevention. There was actually some recent work, although this is controversial, suggesting that the opioid system might underlie the antidepressant actions of ketamine itself. And more recently, that some medications that directly target the opioid system, including buprenorphine and naltrexone, may hold promise for reducing suicide risk as well. So why the opioid system? We talk a great deal in the US particularly about the opioid crisis. There's understandable concern about opioid affecting medications. So why is this something we would have interest in? For a couple of reasons. There's multiple lines of evidence now that have implicated endogenous opioid dysfunction in the pathophysiology of trauma-related psychopathology, including PTSD and BPD. For example, there's a dense concentration of opioid receptors in the frontolimbic network of regions that we know are involved in both PTSD and BPD and implicated in suicide. Opioid receptors have a capacity to produce euphoric and mood-altering effects and have long been implicated as potential targets for mood and emotion dysregulated difficulties like we see in PTSD and BPD and like are implicated in suicide behavior. And more specifically, there's cross-modal evidence for opioid function playing a role in things like impulsivity, pain modulation, and sensitivity to rejection, which are present in BPD and are linked to suicide risk. And in fact, researchers have actually hypothesized, specifically Barbara Stanley, the late great Barbara Stanley, that the dangerous, impulsive, and sensation-seeking behaviors that we commonly observe in borderline personality disorder and have linked to PTSD as well, including opioid abuse, including self-injury, for example, may result from efforts to compensate from a baseline dysfunction in the endogenous opioid system. So what we might be trying to do is to simulate opioid release through, for example, self-injury and sensation seeking. And in support of this theory, researchers demonstrated lower basal opioid levels in both plasma and CSF in individuals with BPD. Also, individuals with BPD on opioid medications report feeling euthymic rather than euphoric following ingestion, which is interesting, right? In terms of thinking about how baseline differences might exist in these levels. Similarly, post-mortem evidence has supported a relationship between opioid receptor availability and death by suicide, which I think is both important and interesting here. Briefly, and this is an oversimplification, if we want to think about where in the opioid system we could potentially target, and we want to avoid worrying about addiction liability, there are three main opioid receptor subtypes, mu, delta, and kappa. Many of the currently available opioid agents tend to target the mu opioid receptor, and that's for a couple of different reasons. Part of it is because of the demonstrated role of mu in reward processing, mood regulation. Unfortunately, though, mu-targeted agents have so far shown limited efficacy in BPD specifically, similar findings in PTSD, and there are very significant concerns about abuse liability, which have pretty significantly dampened enthusiasm as well about continuing to target mu for drug development in both of these conditions. Similarly, while agonism of the delta opioid receptor has the potential, as we've seen in preclinical work, to decrease levels of anxiety, move depressive-like behaviors, research is still ongoing, but we have some concerns regarding potential observed convulsive side effects, which has kind of stalled research in development of potential delta affecting agents. So we still need more research. There's still potential to have agent development affecting these that could have implications for suicide risk, implications for borderline and for PTSD. But fortunately, there's also another viable and potentially promising alternative target, and that is the kappa opioid receptor system, which significantly here, I think, has been shown to mediate dysphoria, particularly under stressful conditions, in which both levels of dynorphin, which is the endogenous peptide associated with kappa, and kappa activity are higher. So far, I'll say up front, there has been no direct evaluation, aside from what I'm going to be showing you today, in kappa of the kappa opioid receptor in BPD or PTSD. But research in multiple fields, postmortem, preclinical, genetics, has substantiated preliminarily the relationship between kappa and core symptoms of BPD. Both kappa and dynorphin play key roles in emotion regulation. Activation of kappa is implicated in development of multiple BPD symptoms like anhedonia, dissociation, and impulsivity. And elevation of dynorphin has been associated with dissociation in human and preclinical work, as well as activation of kappa being implicated in or being shown to mediate rejection of conspecific animals in preclinical research. That's important because it could implicate a role for kappa in the difficulty and maintenance of interpersonal relationships, which are chronically unstable in BPD, have been shown to be problematic in PTSD and to drive more severe symptoms and difficulty benefiting from treatment, and as an important risk factor for suicide behavior. And recent preclinical evidence has suggested that kappa activation mediates the relationship that we see between pain and depressed mood, and it does that by depressing mesolimbic dopamine release specifically. That role between kappa, pain, and social functioning specifically, I'll just highlight again, is particularly significant because pain sensitivity and social deficit are not only central to PTSD and BPD, but they're powerful, robust, consistent predictors of suicide behavior. So again, indicators that there might be a role for kappa. It might be a useful treatment target to consider. Postmortem evidence has also linked kappa expression, including lower kappa availability in the amygdala and ACC specifically, to suicide mortality. And kappa antagonists have shown promise, although preliminarily and mostly in preclinical studies, human clinical trials are now ongoing, to reduction in depressive and anxiety symptoms. So together, these studies provide strong evidence that kappa could play a role in the pathophysiology of PTSD, maybe BPD, but so far, prior to what I'll show you today, kappa availability hadn't been directly investigated in vivo in people with BPD or PTSD and hadn't been investigated with respect to suicide in either of these clinical populations. So that's the work I'll be presenting today. And in terms of a theoretical model, in terms of how we thought that these constructs and neurobiological substrates might be related, we developed this based loosely on Marshall Linehan's very well validated and often cited biopsychosocial model of BPD development, which is in and of itself basically at its heart just a diathesis stress model. So here's what we think the relationship might be. The combination of neurobiological vulnerability and trauma exposure or chronic stress leads to a chronic elevation in dynorphin in individuals with BPD and potentially PTSD as well. That chronic elevation in dynorphin, which by the way is a pretty consistent finding cross-modally in the research literature for some years now, increases kappa activation, and that leads to symptom presentation. And I list analgesia, social deficit. I could actually even add some symptoms here based on the literature that we just talked about. And all of those symptoms exacerbate suicide risk, which in turn, the experience of all of these symptoms as well as suicide risk adds to the likelihood of continued stress as well as the experience of trauma, leading to a vicious cycle. All right. So this was our theoretical model. This is what we thought might be happening. And we were able, for the first time, to directly investigate this in the living human brain using positron emission tomography, which is a dynamic imaging technique that facilitates our ability to image molecular targets like kappa opioid receptor in the living human brain. We accomplish that by injecting a very small amount of a radio-labeled substance or drug, a radio tracer, peripherally. And importantly, these radio tracers are designed specifically not to have any biological effect and to bind selectively and specifically to the target that we're interested in. I'm going to go into just a little bit more detail, diving deeper into how we produce these targets and how it is that we produce what we're interested in terms of PET data. So that's going to start with production of the radio tracer. And we do that including ECAP by which we used for the present study by selecting a substance that binds as best we possibly can with selectivity and specificity to whatever target it is that we're interested in the brain. Then, once we have that substance, with the help of a cyclotron and a team of dedicated radiochemists, we label that substance with a very small amount of a radioactive material. And then the radio-labeled material is injected peripherally into a participant, travels throughout the body, and then the PET scanner detects the decay of the radioactive material, or positron emission, and uses it to estimate where the radio tracer has bound in the brain for this study specifically is what we're interested in. Finally, that data is aggregated to get an overall picture of, for this study, receptor availability in the living human brain. So this is a grossly oversimplified overview of the process, but hopefully it gives you a general idea of what I'm going to be presenting today and some idea of what PET allows us to do. With this technique, we can perform in vivo imaging in humans and thus relate what we see in the living human brain to whatever behavioral and cognitive variables are important and meaningful to the subject population. Things like suicide behavior, suicide ideation, mood, symptom presentation. We can create an image that's representative of available receptors and look at changes in receptors as a function of things like disease state, and measure receptor occupancy based on the application of exogenous drugs or an exogenous neurotransmitter release which we can trigger. The key here really that I want to highlight, because it's important to understanding the results I'm going to report, is that what we measure with PET is occupied receptors, available receptors, not every receptor in the living human brain. So what do I mean by that? So what typically happens in the brain is that some receptors are occupied by an endogenous ligand. So I want you to imagine with me for just a second that this is a kappa opioid receptor. And what you see here in this case is dynorphin. And dynorphin is occupying, in this case, to start out with, 2 of those kappa opioid receptors. And what that means is that ECAP, which is the radio tracer I'm going to be displaying data for today, can bind to the 2 available receptors. Okay, so that's the availability here. By contrast, when dynorphin levels are low, and that could be either due to disease, it could be due to depletion through experimentation, more receptors are available for the radioligand to bind, so we would observe higher receptor availability. Likewise, if there's too much dynorphin, as is the case as I noted through chronic stress, fewer spaces for the receptors to bind are available, and therefore we're going to see lower receptor availability. So receptor availability is just that. How many receptors are available for the radioligand to bind doesn't represent the total number of receptors that a person might have. And what we do is we aggregate receptor availability to get parametric images like these. And just to quickly orient you to reading these images, which differs from other imaging techniques like fMRI, for example, which can use colored images to represent t-tests, comparing different conditions. Here, receptor availability is represented by the colors, where warmer colors indicate higher receptor availability. The cooler colors are going to represent lower receptor availability. This is actually a radio tracer that we've used commonly in the lab that allows us to quantify mGlu5, a glutamate receptor of interest. I also want you to quickly notice these are excellent images, high uptake in both cortical and subcortical regions, but I also want you to notice that there is a difference here in cerebellar binding. So in the rat images that I've got at the bottom for you to notice here, there's really negligible binding in the cerebellum, but that's different in the human images, right? So this is important because of how we quantify our outcome measure in PET. So what we often like to do is find a reference region, which is a region completely devoid of specific binding for whatever receptor it is that you're studying. So in simple terms, our outcome measure, if we were able to find such a region, would be the ratio of the high binding region to the region that was completely devoid of that target. The fact is, though, for many radio tracers, including the one I'm going to be discussing today, this just doesn't work. The reason everyone would prefer to use a reference region model is that that method negates the use of additional IVs, or in the case of studies like mine, arterial lines, that reduces things like subject burden, risk, a lot of different things that are required for the study. However, if you're not getting correct scientific data, then you're exposing the subject to potentially experimental conditions that are dangerous, uncertainty, not sure that your data is as accurate. So of course, there are times and situations where you can't get blood, and then you do the best you can. What we do in cases where we have blood is we use a ratio of the region where there's specific binding to a region where to the region in to plasma, as I'll show you in just a moment. So this is the tracer I'm going to be referring to today. It's 11C ECAP. This is a 2nd generation Kappa agonist radio tracer with excellent imaging properties. Binds to the same site as dynorphin in this case. And this is just evidence from a blocking study. These are parametric images from a blocking study specifically with an naltrexone. And I'm really just showing these so that you can see cerebellar binding. We would love to have a region that's completely devoid of kappa. Unfortunately, we really don't have a good, effective, available region to use. And so volume of distribution is our chosen outcome measure. Given the lack of suitable reference region, today the outcome I'm going to be using is VT, or volume of distribution, which is the ratio of activity in the specified region that I'm going to be looking at to that in the blood, metabolite corrected. Okay. And for the specific study I'm going to be discussing today, we had a couple different regions of interest. We selected these specifically because of their relevance to the conditions that we're interested in studying. So to the pathophysiology of BPD and PTSD, as well as to suicide based on previous neurobiological research. So frontal regions, including the DLPFC, OFC, VMPFC, the anterior cingulate, as well as the amygdala, insula, and hippocampus. And what we did, because we're always concerned about power in PETs, because it's an expensive methodology for a variety of other reasons, was we are able to collect whole brain data, but we combined the regions for an outcome measure that gives us a mean corrected, a weighted mean VT value that sums across all of these circuit regions. Okay. In terms of acquisition and analysis, ECAP was injected as a bolus, and subjects were scanned for 120 minutes, so this is a longer scan. And again, outcome was volume of distribution. This is our sample so far. This sample I'm going to be presenting is the result of a combined series of pilot studies from a number of different funding sources, as well as an ongoing R01 project. So it isn't yet complete. Even still, this is a roughly balanced sample across things like sex, age, and smoking status. We did also examine the relationship between sex, age, smoking status, medication status, and our outcomes of interest to see if those were things for which we might need to covary in order to best understand the results. Okay, so broadly, what are our findings? Combining across diagnostic groups first, so looking at all of the trauma survivors in this study, we see an overall group difference between individuals with BPD and PTSD. They have lower kappa availability than individuals who are healthy controls. And I'll note here also that we have a relatively stringent definition of healthy controls in our inclusion-exclusion criteria. All of our healthy controls not only could have no psychiatric history themselves, none of their first-degree relatives could have a psychiatric history. So we've got a pretty robust difference here, 19% difference and an effect size of almost 0.8. And this is just that visually represented. I'm showing this in part because I'm very excited about this. I want to note that this is the first time there are actually no published papers on parametric images for our kappa opioid tracers. For the ECAP11 tracer, the MA1 model that we use produces a fair number of outliers, often due to noise probably, which results in images that often appear to have holes. To address this, for the first time, our collaborator, Dr. Mika Naganawa here, was able to apply likelihood estimation graphical analysis, or LEGA modeling, to generate this parametric image here for us, which means that we were able to actually see a parametric image with kappa for the first time, which is averaged across groups, which I think is pretty cool. I'll note that for now, this is for visualization purposes. Mika's in the process of rigorously validating this approach for absolute quantification, but I think it's promising and neat to see that we're heading in this direction. So if we want to separate out these results across diagnostic groups, I wanted to first see, okay, is there a relationship more broadly between kappa availability and the experience of trauma? So in this case, initially, I defined that as PTSD's criterion A1 trauma. So a life event or an event in one's life that could potentially have resulted in life threat or threat to a loved one. And in this case, you can see there's no difference in kappa availability as a function of trauma experience. To be fair, a lot of our sample was trauma exposed. So there was a much lower N in one of these groups than in the other one. But what do we see when we break individuals out as a function of diagnosis? Here we are. So we see that there are group differences in just individuals with BPD. lower kappa availability relative to individuals in the healthy control group. There are also significant differences, though smaller in magnitude, in individuals with PTSD relative to healthy controls. But there are no differences between these two clinical groups, okay? So no differences across the trauma survivor groups as a function of their clinical diagnosis. But what's the clinical significance of these findings? Is kappa availability related to symptom severity, for example? Do these group differences matter? So here's what we found with respect to clinical relevance so far. We see a trending correlation with overall PCL severity. That's the PTSD checklist, which is a well-validated measure of PTSD symptom severity, self-report in this case. But we do see relationships with re-experiencing symptoms as well as avoidance symptoms, which are also the two symptoms in the literature that are most linked to suicide risk in PTSD, which I think is really interesting. I'll note here also that while our BPD participants were not allowed to have comorbid PTSD, a lot of them do have subclinical symptoms of PTSD, and so were, if they had a trauma history, given the PCL as well, and they are included in this data. There was no relationship, however, between BSL total score, that's a measure of intensity of BPD symptom experience, or CAPS-5 total score, which is a clinical interview that indexes PTSD symptom severity. We do have another BPD symptom measure that we do see clinical relationships between that and Kappa. I'll talk about that a little bit later in the context of the dynorphin analyses I'm going to present to you today. We also see relationships, which I think is interesting, between Kappa, specifically lower Kappa, and the intensity of childhood trauma. Both adverse childhood events, the number of those participants reported experience, and things like childhood emotional abuse and parental neglect, which is very interesting. For the context of this, I presented these findings broken up by color. So throughout these results, you're going to see, and I apologize for not pointing this out earlier, hopefully it was obvious visually, PTSD is presented in blue and BPD is presented in purple. So the blue dots here are individuals with PTSD, the purple dots here are individuals with BPD, and you can see that the findings really don't differ. That's a consistent pattern throughout our clinical findings. There really aren't group differences in the relationship between Kappa and any of these clinical scales as a function of those two diagnostic groups. Okay, but what's the relationship between Kappa and suicide risk? I've been talking about suicide a great deal. The primary way that we looked at that in the context of this study, because I also talked a great deal about the importance of looking specifically at suicide behavior and really thinking about how you are conceptualizing suicide. We looked at history of suicide attempt. We were interested in that. We were interested separately in suicide ideation and at potential risk factors for suicide like impulsivity and emotion dysregulation, all of which we indexed on scan day so that we could look at their relationship to Kappa availability in these different populations. So if we separate out individuals who do and do not have a history of suicide attempt, we see some really interesting differences, in my opinion. We see significantly lower Kappa availability in individuals with BPD as well as PTSD. So this is the combined group first, who have a history of suicide attempt relative to healthy controls. We also see lower Kappa availability in individuals who have a history of suicide attempt with a trauma history relative to those who don't. So a 17% difference here, about the same size difference as we saw for the whole group versus the healthy controls, which I think is interesting. But, and I think this is important, there's not a significant difference between individuals with a trauma history without a history of suicide behavior and healthy controls. So the question becomes, is this an effect of suicide history and what goes along with that and maybe clinical differences in the suicide group? Or is this an effect of diagnosis? I think this becomes an open question given this finding. But is this diagnostically specific? So here's what we find if we break the findings down by diagnosis. In BPD, We see a difference, lower kappa availability in individuals with BPD with a history of suicide attempt, not individuals without a history of suicide attempt. And we see the same finding with similar magnitude in individuals with PTSD, but no differences across individuals with a history of suicide attempt in PTSD versus BPD, or history or lack of history of suicide attempt in PTSD versus BPD. Those groups look very similar as a function of attempt history or lack thereof in Kappa, which I think is really interesting. Okay. In terms of what we think about occupancy, I noted earlier, right? We didn't hypothesize necessarily that what we were seeing was lower kappa availability as a result of internalization of receptors. What we thought was chronic stress results in more dynorphin, and more dynorphin is going to result in higher occupancy of receptors. We can't directly measure that by looking at dynorphin levels in the brain, but we can look at dynorphin peripherally. And so we did. And here are the results of that. So we looked at dynorphin and its relationship to frontolimbic kappa availability, and we saw something that appears, at least preliminarily, to confirm my hypotheses. So higher dynorphin was associated with lower kappa. Not only that, but when we look at clinical relationships, both with kappa availability as well as with dynorphin, we see an opposite pattern. So the McLean here, I mentioned I was going to talk about another measure of BPD symptom severity. That's the McLean. So we see a 0.7 correlation between dynorphin and BPD symptom severity in a positive direction, and the opposite, negative 0.7 or 0.67 in kappa availability. We see opposite correlations as well in things like empathetic concern and PTSD symptoms of anxious avoidance. And there's this interesting relationship between dynorphin and depressive symptom severity, no relationships between kappa and depressive symptom severity across the board, which I think is interesting. I'll also note here, though, there's a couple of meaningful outliers. They don't fall outside of the expected range of what's a reasonable value for dynorphin, and just because we want to be sure of these findings, I did remove them, wanted to see what we would end up finding, and we do still see a trending correlation in the same direction. So again, we're still collecting data for this study, but I think this is an interesting and potentially a promising and illustrative finding. But what else do we see? What are relationships between kappa and those other clinical variables of interest and things that I described to you earlier as suicide risk factors? So we see, consistent with hypotheses, lower kappa availability is associated with more impulsivity across individuals with trauma-related psychopathology. Lower kappa is associated with more emotion dysregulation. Lower kappa is associated with more worry and more difficulty getting sleep, both of which are also risk factors for suicide behavior. And interestingly, lower kappa is linked to variables associated with the interpersonal psychological theory of suicide, including the sense that one is a burden to others and fearlessness about death. I thought this was really interesting, though. There's a lot of variability here in how people responded. This is technically a significant correlation, but I started really thinking about our suicide data, thinking about how we define and think about suicide, and thinking about the variability in this data and wondering, should we really be lumping all of our individuals who have a history of suicide attempt together? Is that appropriate? Or otherwise stated, is it reasonable to think about a single neurobiology of suicide? And this wasn't my original idea. I was inspired by, I think, really meaningful work from previous researchers, including Maria Okendo and Barbara Stanley, who have showed previously that there are potentially distinct neurobiological and biological phenotypes that may distinguish people who experience suicide behavior in different ways. Specifically, they showed a different relationship between 5-HT1A, so serotonin 1A, and suicide behavior. It was relevant in individuals who exhibited planful suicide behavior, but didn't seem relative in individuals who ended up having impulsive suicide attempts. Really interesting, right? So might we be needing to think in a more nuanced way about the nature and the neurobiology of suicide? I think it's possible, in part because I'm a trauma researcher, and a lot of what we see in the context of trauma is more impulsive suicide, which looks different clinically, and therefore I would expect to look different neurobiologically as well. So what I did, we had the benefit of really detailed, very behaviorally specific interviews about past suicide behavior. So we were able to break individuals down into people with a history of impulsive suicide and people with a history of planful suicide. There were a couple of people with both types of attempts, and those people we didn't classify because I didn't feel there was a way to fairly or accurately make that decision. But we do see, interestingly, that people in the trauma-related psychopathology or BPD group who had a history of impulsive suicide had lower Kappa availability than every other group, including individuals with a history of planful suicide, including a 41% difference, or an effect size of 1.23 relative to healthy control. So pretty robust differences. And if we look at these clinical relationships, picking out individuals with a history of impulsive suicide, no relationship really with fearlessness about death. A lot of individuals are reporting pretty high fearlessness about death in this group, which I think is interesting and concerning. Some quite inconsistent relationships, so lower Kappa being associated with better evaluation of overall health and functioning, less depression, and less worry in this group. Some more extreme findings, including lower Kappa being associated with much more extreme sensation seeking relative to the full sample and more parental neglect relative to the whole sample. And interestingly, hearkening back to those EMA findings that I presented at the beginning, results showed at the beginning of the day, participants who had a history of impulsive attempt showed greater variability in responding relative to individuals who had a history of planful attempt versus non. So there's one measure, the profile of mood states. It's an index of mood variability and lability. We give it multiple times throughout the scan day, mostly because we wanted to be able to see whether or not these different time points were differentially related to our PET measure. There was a very interesting study with BPD and mu opioid receptor that showed variability as a result of mood induction pre-post scans. So we wanted to see if proximity to scan mattered in terms of mood. We didn't expect to see this much variability. I think that variability and the potential variability in reporting, variability in mood is clinically meaningful and is very interesting here. So potentially, there's an implication for these results in terms of thinking about Kappa in the context of the neurobiology of impulsive suicide attempts specifically. I think we have more work to do. But I think in terms of preliminary findings, this is something I'd like to continue to explore further. Another thing that we've been doing that I'm excited about and I think is potentially promising is we've been following up with participants. So we've gotten permission to follow participants with electronic health records and see who goes on to engage in suicide attempts and who, unfortunately, we have lost to suicide. I am sorry to report that we have lost one individual and 5 individuals who've completed our study since 2022 when the first pilot began, have attempted suicide since completing our study. This is a very high-risk group, so not surprising, unfortunate to hear always clinically. And those individuals who fall into that group do have lower Kappa availability. So they did have lower Kappa availability when they were measured. Their Kappa availability also did account, when we put this into a regression analysis, for about 20% of the variance in predicting who would be in the future suicide behavior group. So we're going to continue doing this. We're going to see if what we measure at the single time point in terms of PET, as well as what we're measuring with MR, has predictive value in terms of looking at future suicide behavior. So what's the clinical significance? What do we take away from this and where do we go next? Kappa, it seems like, preliminarily, has the potential to be a meaningful treatment target for both of these forms of trauma-related psychopathology. It could also potentially be a biomarker for suicide attempt. Another thing I want to add here that I think is potentially meaningful is if we look at suicide attempts and things like recency and lethality, there's no differentiation in terms of Kappa. So it doesn't matter how recent the attempt was, although a lot of these attempts were pretty recent, the average was 10 months for the BPD group in terms of recency of attempt. So it's a little bit difficult to gauge. We don't have a whole lot of very distal attempts in this research. It could potentially have utility ultimately in risk prediction and prevention, although we're very, very early on in terms of being able to make any type of assertion along those lines. I think there are some interesting implications here in terms of the potential differences that we see with reference to the neurobiology of suicide as a function of diagnosis, as a function of different suicide behaviors, and needing to think really critically about how useful it is to have a single model of suicide behavior versus looking at different suicide behaviors separately, or even different pathways to specific suicide behaviors differently from a neurobiological perspective. I want to quickly note some limitations. There are a lot of real advantages to using the tracer that we used. It's been extensively validated. And while test-retest values across most regions averages at 4%, the test-retest value was 17% for the amygdala. We still included this in our circuit because it's one of the regions that is of central interest for the neurobiology and of relevance to the neurobiology of all of the conditions that we're interested in looking at, certainly for suicide, and it's something that we really have to think critically about and that is relevant in terms of interpretation of these results. We also always have to balance selectivity and specificity of the opioid system. So finding a tracer that binds more to Kappa and not to everything else is something that we have to be mindful of and is a very real challenge. So what's next? What are we planning? What do we think is going to come out of this? We are, as I mentioned, in the middle of an R01 study. So we're extending this, we're continuing, we're going to collect data from 98 individuals in addition to what we've already got. We've collected from a fair number so far, but we've just finished year 2. Long term, we're going to hope to do EMA and then rescanning so that we can look at change in Kappa over time and its relationship to suicide risk. We've got some really interesting findings based on what we've got so far between Kappa and pain, particularly chronic pain, and its relationship to risk for things like social disconnection, which can relate to things like whether or not people benefit from treatment in both BPD and PTSD, and whether or not that can translate to things like suicide risk. We've got some fascinating findings, in my opinion, in terms of Kappa and opioid use disorder, which is highly comorbid with borderline personality disorder. I've actually got a slide on that if anybody is interested that I'd be happy to show a little bit about preliminarily. We're also connecting dynorphin samples from CSF as part of a pilot study, which I'm excited about, and I think will give us a little bit more of a direct look. We'll see if those findings differ at all. It's something a little bit closer to brain. And then some exciting preclinical translational work that'll let us look a little bit more at how and why trauma develops and if that relates to Kappa. I've got some slides on that as well if anyone has interest and we have time. All with the goal, ultimately, of expanding our understanding of trauma-related psychopathology and its neurobiology in order to understand suicide risk, inform treatment development for all of these conditions, and develop effective targeted treatment options. All right, I want to acknowledge everybody without whom this work could not have occurred. My long-term mentor, Dr. Irina Esterlis, everybody in my lab, Rich Carson at the Pet Center, Mika Naganawa, as I mentioned, Ruth Ash, who's my preclinical collaborator, and everybody else at Yale. And I'd be happy to take any questions. Thank you so much.
Do you think that the signatures that you see in the Kappa system are like a trait of these people, or are they induced by the suicide attempt?
Yeah, it's a great question. I think it's trait level. So I do not think this is state level. I think it's trait level. And I think that is, my confidence in that was increased by the fact that there's no relationship between recency of suicide attempt and the Kappa findings. I think Also, the relationship between things like impulsivity and emotion dysregulation and the things that we also associate clinically with likelihood of impulsive attempt specifically make me more confident in the fact that these could all be, Kappa could be associated with the things clinically that make somebody more likely to engage in an impulsive suicide attempt. So if we can move Kappa potentially, we can move the things clinically that put somebody at risk for an impulsive suicide attempt.
I love you thought to repeat it, but I'm curious if you looked at either sex, age, or like treatments that people were receiving and how they related to the Kappa.
That was the
Yes,
question.
we did. We do have some sex differences. So we saw lower Kappa availability, and this is a pretty consistent finding now in males relative to females. And that difference is more pronounced in the BPD group, which I think is really interesting, particularly because historically we see undertreatment of males in BPD. Not only undertreatment, under referral, and when BPD males are in treatment, we have much more difficulty getting successful treatment for this group. This is a group we worry about a great deal. Part of the reason, so there's a really interesting difference clinically in terms of sex differences in BPD. Clinically, we see a much higher number of females who are diagnosed. So like in inpatient samples, you see an overrepresentation of females. If you look at epidemiological samples, you see a 50-50 split between males and females. I think a part of this is because you see a lot of externalizing behavior dysregulation type of behaviors, things like substance use and impulsive behaviors and associated with BPD. And those are more prevalent, they're more likely to occur in males. Part of that probably has to do with the way we socialize in terms of gender and sex. And so I think men with BPD are more likely to, at least at first, be diagnosed with a substance use disorder or with antisocial personality disorder or to be put in prison instead of being successfully treated with things like borderline personality disorder or even PTSD, unfortunately. So I think the potential promise for us to move symptoms of BPD with something like a Kappa antagonist in males is something that I'm very excited about. Thank you for asking.
All right, I think we are on time. If you have more questions, I think you could arrange a meeting with Maggie. You can let me know and can set you up. Thanks for coming. Thank you so much, Maggie.
Thank you very much.